Florida, received her JD from IU Maurer School of Law in 2013. She began her postdoctoral research position at IU School of Public Health in August of 2016, where she did research on prescription painkiller overdose prevention and treatment programs. She also has published many articles and presents her research at legal and health conferences. She's going to speak for about 45 minutes, and then we'll open it up for questions. I'll have you come to the middle where I'll move a mic out into the middle aisle. So we will get started.
Good morning, everyone. Thank you so much for having me. As she mentioned, I actually have a JD, so I come from a legal standpoint, which has been very interesting. I focused a lot on legal regulations and other barriers potentially to treatment. And over time, I've gotten to know more and more physicians, and eventually was able to interview quite a few to get their perspectives on barriers to treatment access, which then led me into a bigger question, which is why are so few physicians treating addiction to begin with? And that's really what this presentation is about. So in order to prepare for this presentation, I did a pretty comprehensive literature review, but I'm also peppering it with information that I learned through interviews with about 23 physicians now. And I'm actually continuing these interviews, so if you are a physician and you would like to share your thoughts with me, I would really love it if you would contact me. What I'm going to be presenting about is really two things. What are some of the problems that have prevented physicians from practicing addiction medicine more? And then what are some of the solutions? Now, the solutions I'm going to present are solutions that I have read about in the literature, I have heard about through interviews with physicians and with counselors. However, I'm sure there are other solutions out there that I haven't thought of, and I would really love to hear your thoughts, and maybe some of the ones I'm presenting you might disagree with, so I'm also very open to hearing those thoughts as well. So I'm going to go ahead and get started here. So why should we even care about physicians being involved in addiction treatment? This may seem like a kind of a weird question to some of you, but I actually get this question, usually not from physicians themselves, but from people in other professions. And it's not really a surprising question, because if you look at the United States, very few physicians treat addiction. And when we think about someone going to get addiction treatment, we don't usually think of them as going to a physician. We think of them as going to a mental health counselor, maybe going to a support group, going to a rehabilitation center that may or may not have a physician working there. So this is actually kind of a new idea to some people. But just to throw out a couple of reasons, and I think there's many reasons. Well, one is that only physicians and then nurse practitioners and physician assistants in certain states can prescribe pharmacological treatments for addiction, such as for opioid addiction and for alcohol addiction. So obviously we need physicians for that. Another reason is SPIRIT, which is screening and brief intervention and referral for treatment. Again, physicians can do this. Now, we have had some studies come out showing that this is not really that effective for someone actually deeply, severely suffering from addiction, but it can actually help individuals with unhealthy behaviors who have not reached that point from perhaps reaching that point. So physicians do have a role to play there, especially primary care physicians. And then additionally, I want to mention two more reasons. So one is physicians just see a lot of patients with addiction in general. Primary care physicians see a lot of patients with addiction. They may not know it, but they do. Psychiatrists do as well, pain management physicians, and OBGYNs. I mean, there's a number of physician practices that a lot of addiction, patients with addiction go to, and they should be able to get some treatment while they're there. And then lastly, physicians have the ability to address other co-occurring conditions. So for example, the patient may come in and actually also have hepatitis C or HIV/AIDS or another condition. And a physician is perfectly placed there to address those conditions as well. So in the United States, as I mentioned, we have a really low rate of physician involvement. And this is not necessarily something we see around the world. In Europe, we have much more physician involvement in addiction treatment, for example, than in the US. But just to give you some statistics here, and there's many others, but I think these really tell a good story here. So CASA, which is the Center for Addiction and Substance Abuse, the National Center, in 2000 published a study where they interviewed 648 physicians, and they found that 55% of physicians reported doing referrals for patients whom they believed were suffering from addiction. That's a pretty low number for physicians to do referrals, especially when you hear in a moment, or in a couple of slides, I'll talk about the number of physicians actually treating patients themselves is even lower. So there's a big gap there. And 15% just did absolutely no intervention whatsoever, meaning they themselves didn't provide any treatment and they didn't refer patients out to another treatment provider. In terms of the survey results for actual patients, there was a really common theme, and this is just one of the statistics, of patients feeling like physicians were really not addressing their addiction needs. And 11% of the patients stated that they knew that their physician knew about addiction in the person's history, or maybe there were a series of urine analysis results suggesting addiction, and yet the physician did nothing. No referral and no treatment from themselves. Another very problematic issue is the low rate of medication-assisted treatment prescribing in the US. As I mentioned, only physicians and some physician assistants and nurse practitioners can provide this treatment. For opioid addiction, we know that MAT combined with counseling is the most effective treatment in terms of preventing relapse, preventing overdose. So this is extremely problematic, of course. And this is a problem that's not just in particular physicians' offices, it's also in addiction treatment centers. So oftentimes, if someone has a person in their family suffering from addiction, they'll look for a treatment center or a rehabilitation center. But what we know is that less than 45% of those treatment centers actually offer any type of MAT. And so specifically, this study looked at whether they offered at least one form of MAT for either alcohol addiction or opioid addiction, and less than 45% did. So that's a really, really low rate. And part of the reason for that is that a lot of physicians are just not involved in these centers. So many of these centers are solely operated with mental health counselors. Maybe they have some support groups, but there's no physician involved. However, that doesn't tell the full story, because we also have a study by Roman et al. In 2011 that looked at centers that did have a physician working there, and even within those centers, 40 to 70% of the physicians did not prescribe medication-assisted treatment. So there's something more than just a lack of physicians in these centers. And in particular, centers that were publicly funded as opposed to privately funded were a lot less likely to have some kind of medication-assisted treatment access, suggesting that, especially for individuals from a lower socioeconomic background, they're going to have a particularly difficult time finding these treatments. For methadone, I'm sure most of you are aware that it can only be prescribed in opioid treatment programs, commonly known as methadone clinics. However, we have many states that either have very few or none at all. In those states, patients routinely report having to cross state borders in order to get their treatment, sometimes daily. And you can imagine how that would interfere with a patient's life, their ability perhaps to try and find a job or make enough social connections to sort of advance in their lives. In terms of Vivitrol, I think that's probably the lowest rate of patients accessing any form of medication-assisted treatment for opioid addiction. So in 2013, there was a national survey of substance abuse treatment services done, and that survey found that only 1% of patients who are eligible for some kind of MAT were getting Vivitrol. That's not to say the other 99% were getting some kind of MAT. They weren't. Most of them were not getting any, but still 1% is very, very low. And finally, buprenorphine, which is something that I've really explored a lot from a legal standpoint in terms of the barriers, has a serious need of more prescribers. So 46% of counties lack a single physician who is certified to prescribe buprenorphine. And if you don't already know, in order for a physician to prescribe buprenorphine, they need to have their license to practice medicine, of course, but they also need to do an 8-hour online or in-person certification course, with the exception for some physicians who have, for example, an addiction specialty background. But then they need to apply to SAMHSA and get a waiver, and at that point, they can start treating patients. So this is a really low number of counties, obviously, with access to one of these physicians. Really fascinatingly, we have 30 times as many physicians in the US who can prescribe oxycodone as physicians who can prescribe buprenorphine, which is kind of ironic if you look at it from a legal standpoint, because oxycodone is a Schedule II medication. So in theory, it should be much more heavily regulated and more difficult to access than buprenorphine. And it also has significantly higher overdose rates associated with it. So I'm just going to show you here a chart, and I unfortunately have it cut off. I'll show you the other half of it on the other slide. It's just a long chart of just the lack of access specifically to buprenorphine. And I want you to keep in mind when you're looking at this that access to Vivitrol is probably even lower. So this was from the Pew Charitable Foundation. In 2016, they published this, and they estimated the number of individuals suffering from opioid addiction in each state, and the relative number of prescribers who are certified in prescribing buprenorphine treatment. So as you can see, there's only really 2 states going above 100%. Vermont, interestingly, is one of them. If you ever want to look at a state that's really done a good job, I would say look at Vermont for a number of reasons. One thing that they did, and I'm not sure about the relationship to this chart exactly, but Vermont has actually made it free for any physician to take the 8-hour online certification course. So I don't know if that's led in part to this high number of prescribers. There may be a number of other factors. So now looking at the bottom half of the chart, if you'll notice where Indiana is, not super surprisingly, at the bottom. Okay, so now I'm going to kind of dive into some of the reasons why so few physicians are treating addiction. And there are a lot of reasons. But I want to start at the beginning, which is, as a lawyer, I need to tell you a little bit of the legal background, because it actually really makes a difference in this case. So in 1914, the United States Congress passed the first ever regulation of narcotics, and it was called the Harrison Anti-Narcotics Tax Act. And basically all that did is it said physicians need to register with the federal government, they need to keep records, and importantly, they can only prescribe opioid medications if it's done in the course of regular, proper practice. Well, at that time, the predecessor to the DEA, which was part of the Treasury Department, decided that it's just not going to be okay for physicians to prescribe maintenance treatment. They decided that can't actually qualify as a practice of medicine. Now, again, during this time period, methadone wasn't yet developed. We didn't have buprenorphine, we didn't have other maintenance medications. So we're really talking about physicians giving very low dosages of morphine daily, regularly from their offices. But they were finding that that was better than having patients go out and either commit crimes trying to get it or taking too high of dosages themselves, and they were overdosing. So actually quite a few physicians were involved in maintenance treatment. Proportionally, at that point in time, we had more physicians providing maintenance treatment than we ever have had, even today, in US history. So at that point, the predecessor organization to the DEA decided this is not okay and started prosecuting physicians. About 10% of those physicians who were arrested were convicted and imprisoned. And at that point, physicians really start to leave practicing any kind of addiction medicine, whether it's maintenance treatment or otherwise, en masse. Now, interestingly, the US Supreme Court then comes in, reviews this, and says, yeah, we agree, this is not proper practice of medicine. Maintenance treatment cannot be allowed. But actually, a couple years later, they reversed themselves, and in 2 other cases, changed their mind, saying, actually, it is okay if it's done in good faith, truly to help the person who is suffering from an addiction, as opposed to just, say, helping people get high or expanding drug use. So at that point, though, physicians had essentially left the practice, and the gap was in large part filled by 12-step organizations and counselors who are really kind of coming into their own at that point in terms of developing new counseling treatment methods. Now, there was a time period in the 60s and 70s and a little bit in the 50s of some psychiatrists providing treatment in the form of psychoanalysis, but that later on was discredited as a treatment that was not evidence-based, and those psychiatrists left as well. So you end up getting this gap. So I'm going to talk a little bit later about regulation of medicines like methadone and buprenorphine, but really it's not until methadone is approved in the 1970s that physicians start to kind of trickle back into addiction treatment. But moving on for right now, one of the problems that I have found commonly in discussions with physicians is that a lot of physicians just assume they don't have patients suffering from addiction. And this is really common among primary care physicians, actually, which is quite surprising because the CDC has stated that somewhere between 4 and 25% of patients in primary care practices have some kind of substance use disorder. So I really doubt that most primary care physicians do not see someone with addiction. Interestingly, most physicians, especially primary care physicians, are not adequately diagnosing substance use disorder, which may lead, of course, to their assumption that few patients have substance use disorder. So the 2000 survey that I mentioned by the Center for Addiction and Substance Abuse found that 94% of the physicians failed to recognize SUD when presented with SUD symptoms. 43% of patients in that studies who said that they had some kind of SUD said that they did not receive any diagnosis from their physician. So why do we have such incredibly low screening rates, or at least diagnoses rates? And I think in part that is due to lack of screening. And this is not super surprising if you've ever been in a physician's office. It is kind of, an uncomfortable, brief interview where you're asked some questions about, your drug use, your alcohol use, along with other medical conditions. And this is, not something that I think as a medical profession, as a society, we've really explored how to do this in a way that is comfortable for both parties involved, both the physician or nurse practitioner or physician assistant and the patient. But another thing is that I just don't think we're screening enough patients, so it starts to feel like certain patients are singled out, as opposed to just screening everyone and making it seem like this is a normal thing, the way we ask for, say, your allergies. So we make sure that we don't prescribe you medication that will kill you. Another reason is low reimbursement rates. So, and I'll get to this on the next slide, but interestingly enough, Medicaid in some states actually does cover the screening process. But most physicians don't know about that in those states, so they just assume that it's actually not covered. Likewise, most major health insurances actually do cover screening, but a lot of times it has to be done using a specific screening tool that has been validated and approved, not just by, say, direct questioning. So again, a lot of physicians don't know about that. And then finally, there's this idea sometimes that this is not really an area of medicine, that maybe this should just be left to the counselors or social workers, and perhaps the physician just doesn't even know about treatment options out there. So it feels like, well, if I find out that they are addicted to something, what am I going to do about it anyways? So my 3 solutions for this are: 1, screen everyone regularly, so there's no singling out of people and it doesn't seem like a stigmatizing activity, but just a normal part of medicine. Number 2 is delegate this task to other types of practitioners. So a study by Harrison and Yu found that 85 to 95% of nurse practitioners and physician assistants report having to screen patients and do physicals on a day-to-day basis anyways. Now, they may be doing it for other conditions, but this does seem like a pretty perfect group perhaps to delegate it to, which then implies they need to have better training also in how to go through what might be an uncomfortable conversation and how to use validated, reimbursable screening tools and measures. Interestingly, I mentioned that a lot of physicians are not using the validated screening tools. There was a study done by Harrison and Yu in 2016, and they surveyed 200 physicians. Now, these physicians were all eligible to be reimbursed by Medicaid, but only 28% actually used screening tools that were approved by Medicaid for reimbursement. The rest relied on direct questioning only. All right, next problem. Simply assuming that treatment is ineffective. And as you can see, this is going to really prevent physicians from entering the practice of addiction medicine. If you feel like you can't really do anything about it, then why bother? Well, one reason for this may simply be that a lot of physicians still view addiction as more of a matter of morality or lack of willpower than as a disease. And in fact, there was a study done in Canada a few years ago with medical students there, where the authors found that the medical students seemed to not act like doctors when they were faced with an issue of addiction. They put on a different hat of being more of a judgmental person, not really approaching it as a medical issue. So I think this is definitely a problem that may exist also in the United States. One thing that we know is that over time in medical schools, students start to feel that addiction treatment is not effective. And actually a number of studies have found this, but a really interesting one in 2010 by Agrawal, Everett, and Sharma did a longitudinal survey of a cohort of 101 medical students. And they found that between year 1 and 3 of medical school, the belief that addiction treatment actually works declined from 47% of people believing it works to 22% of the students believing that it works. Likewise, between years 1 and 3, the students felt that the role of physicians in addiction treatment should be less as they progressed during their medical school years. So one of the reasons for this may simply be lack of awareness of valid evidence-based treatment methods that physicians can do, such as various forms of medication-assisted treatment. Another reason may simply be assuming that patients are not satisfied with medication-assisted treatment. And we know, for example, in the case of buprenorphine prescribing, that many physicians who are not certified to prescribe buprenorphine just assume patients don't want it or they don't like it. Whereas obviously you don't see that with most physicians who are prescribing buprenorphine. So one important solution, I think, is for physicians to do training in longitudinal settings where they see addiction as a chronic disease that over time can be treated despite relapses, as opposed to in acute settings. And so one of the theories behind why medical students oftentimes begin to view addiction treatment as ineffective over time is because they're exposed more and more to these acute situations only. Inside a hospital, inside an inpatient treatment center, they'll see short-term treatment, and then say a month later, the patient reappears and in the meantime has gotten no real follow-up or care in the community, and it just may begin to look to the physician like this is an acute condition that just does not really have any effective treatment methods. Well, if a physician sees the same patients over time in an outpatient treatment center, a longitudinal center where that patient is going over and over again, perhaps for months, then that physician may be able to view this more like a chronic condition that has treatment success comparable to, say, hypertension or asthma, which is actually what the data shows. Another important thing for physicians to learn about, in whether it's in medical school or in CMEs, continuing medical education, is the fact that addiction treatment doesn't just work on addiction itself. Addiction treatment works on other conditions. In fact, it's very effective for dealing with things like HIV/AIDS or hepatitis C, or even some co-occurring mental conditions like depression can be very deeply integrated with addiction. So even if the physician doesn't feel like the addiction itself is being treated, these other conditions may at least be having harm reduced, if not, getting completely controlled. One last thing I'll mention is that I do sense sometimes in my interviews with physicians that there is a little bit of an abstinence-only ideology that exists either within their own mindset or even within medical schools today. So a belief that medication-assisted treatment is simply substituting one drug for another. And now the American Medical Association has repudiated this idea for over a decade now, but somehow this idea is still out there. And I'm gonna jump right into education next, but I think that needs to be one of the things that is reiterated in medical school and continuing medical education courses, that this is not substituting one drug for another, because the person is functioning better, and the person's mortality rates are lower, morbidity rates are lower. So there's definitely a difference between taking MAT and abusing some kind of drug. So looking at the education gap, this is really the number one thing that I hear about in interview after interview after interview. physicians will say, especially primary care physicians, I did not learn how to treat addiction. I do not feel comfortable treating addiction. I want to leave it to someone else, like a psychiatrist who probably got more education, and I'm just going to step out of this. Well, as you can see, this is pretty well reflected in the data. So in the early 2000s, the Institute of Medicine published a report saying that only 1% of the educational curriculum in medical schools was devoted to substance use disorders. Since that time, there has been more education about it in medical schools, but typically it's about 12 hours. That's the rate that was published this year. And it's usually only kind of dispersed throughout other courses. It's not usually presented as its own course, which is very important for one thing, because you might not get the same quantity of information if it's kind of dispersed throughout as opposed to being in one course. But it also signals to medical students that maybe this is not an important enough topic to have its own course, when it really is and should have its own course. Additionally, there is a low quality of education reported in multiple studies. I know a director of one fellowship program who said that before he took over, one of the main methods of educating fellows was actually just going and sitting in an AA meeting and just seeing what that was about, and that was essentially the extent of education about addiction. A study by Wakeman et al. In 2013 of internal medicine residents found that only 6% could properly recognize the pharmacological mechanisms of various medication-assisted treatment medications. And that's pretty recently, in 2013. So you can imagine now if a physician, say, graduated from medical school or finished their residency a decade or 2 decades ago, how low the knowledge rate is going to be there. And one thing that I hear often in interviews, but also is expressed frequently in the literature, is just a lack of faculty in medical schools who have a background in addiction medicine. And obviously, if you have fewer faculty in this area, you're going to have fewer classes, because who's going to be teaching the classes? And you're also going to have fewer mentors for physicians to see themselves in the future as. Mentors, we know from various studies, are very important in helping medical students develop a role, an idea of themselves in the future as performing certain tasks. So saying, I can see myself like him or like her. So I think simply increasing the number of faculty members is one step that can be taken. Obviously not a full solution, but that's an important step to take. As I mentioned in residency, we know already from the Wakeman et al. Study that many students or residents just don't even know about the mechanisms of MAT. But in particular, one study in 2011 showed that 62% of residents said that they just do not feel prepared to treat addiction, period, in their practice. And then practicing physicians is a particularly prevalent amount among primary care physicians. So 90% say that they feel unprepared, and that really goes right along with what I see in the interviews, just total feeling of I can't do this properly, therefore I'm not going to do it at all. Oh, and one thing, let me go back here. The American Society of Addiction Medicine did a survey earlier this year, I believe it was in January, where they asked psychiatrists who were associated with the American Society of Addiction Medicine whether they feel comfortable prescribing buprenorphine, and the vast majority said they don't. And again, those were psychiatrists associated with a Society for Addiction Medicine. So you can think about, in general, how many psychiatrists may feel uncomfortable prescribing buprenorphine and even other drugs. So what are some of the solutions here? As I mentioned, forming one's professional identity occurs during medical school, especially in collaboration with mentors. So one thing is really targeting students in their preclinical years, exposing them to these mentors, exposing them to these subjects, and helping them start to see themselves as practicing addiction medicine, whether it's their main area of practice or just part of another type of practice, whether it's primary care or being an OBGYN, for example. Another thing that's important and often underlooked is education related to empathy. So we know from many studies, not just in medicine, but also counseling, that expressing empathy towards a patient is very important, not only for the patient-practitioner relationship, but also for clinical outcomes of the patient. In fact, in certain counseling studies, we've seen that that may be the most important factor, more so even than what type of counseling is being provided. So we see that a lot of empathy is lacking, actually, among especially medical students and residents, and that's, current ones. So who knows about ones that graduated 20 years ago even, when education totally didn't address this topic. So one thing that I would propose is to have in these courses that would ideally be standalone addiction medicine courses in medical school, some kind of component that would address attitudes, especially attitudes like this is a choice, this is a unmoral behavior, as opposed to this is a disease, it's a chronic disease, and these are really normal people. Another idea that was mentioned by a handful of scholars was encouraging physicians during their clinical years to do volunteer activities in which they would interact a lot with patients suffering from addiction, whether it's at a homeless shelter or some other type of area, so that they can start to see the many social and cultural and complex problems that surround these issues, as opposed to just seeing it from a purely pharmacological standpoint. And perhaps these volunteer activities could be used as elective credits. One thing I'll mention in the end here on this slide is the federal government really should be more invested in this, whether it's in terms of funding or otherwise. So a study came out in Health Affairs in 2012 that said $500,000 is spent per graduate medical student by the US government, and that's not including subsidies for loans. It's purely the money that goes into the medical schools and faculty training, and obviously they're taking a lot of factors into account. But all this is to say that the federal government probably has a stake here, and the federal government can either start providing more money for these particular types of education, or it could even withhold certain medication or certain education money by saying if you don't have at least one class in your medical school about SUD, then you're not going to get as much money. So there's definitely, I think, some kind of role the government can play, at least at this point in time when we're in the middle of an overdose crisis. So moving on to education in clinical years, I already mentioned that it's really important for physicians to see patients suffering from addiction in longitudinal treatment settings, say over the course of multiple months or a year, where they see the patients improve over time. What I did mention is that a lot of treatment settings don't use evidence-based practices, or maybe I mentioned that at the beginning, where less than 45% of treatment centers provide even one single form of MAT. So part of this would require medical schools to reach out in their community and look at what treatment centers are actually using evidence-based practices. Ideally also which treatment centers have multidisciplinary teams, so physicians can start to see themselves in relation to other treatment providers like counselors and social workers and learn how to interact with them. So I think this is an area that, of course, medical schools should step in and get involved. And finally, this is something I have interestingly heard a number of times from existing medical students and students who have gone through their residency recently. They feel like there should be some kind of questions about addiction medicine on licensing exams, because according to them, if you just add more education, there is so much information that they're already learning in medical school, they simply don't know where they're going to have the time. Well, you can force people to make the time if you incentivize them, for example, through exam questions. Likewise, having a licensing exam question or series of questions about these issues would incentivize medical schools to start having more courses about these issues, as well as medical schools really want to prepare their students for their licensing exams. And then finally, in the time of residency, I mentioned again, really low levels of comfort existing, that all will transition immediately when the person goes out to practice, especially primary care physicians going into practice. So at this time, this is when students, residents should really be reinforcing a lot of the things that they've already learned during their preclinical and clinical years. And during this time may also be an ideal opportunity to get residents, at least in certain types of residencies, to start taking the buprenorphine certification course, and also learning how to use other forms of MAT. One thing I'll mention is that SUD education should exist in some form in every residency. So obviously some of it exists currently in psychiatry. But that's not the only place for it to be. So an OBGYN resident, a pain management resident, you name it. There are a number of areas where at least some element of SUD education should be involved. So training for practitioners. So what I mean by this is practitioners who have already finished their residency, they're out, maybe they've been out for decades. So, changing the medical school curriculum is not going to do anything for them. We need to, as a society, as medical schools, as a government, really target these individuals. And there are some programs in place, but they're really underused and underfunded. So one thing we know is that even brief training works. That's the great news. Even providing a couple of hours of training about evidence-based practices to physicians, studies show that works. The bad news is it only works in the short run. So in order for someone to change behavior over time, they really need to have it reinforced, or they're going to just divert to what's more comfortable for them, which may be simply to not screen patients at all, or not provide any referrals or brief interventions. So providing ongoing training is really important. And one option is to go through the